I am so glad to introduce you our next speaker. Dr. Pietro Manzini is not any speaker for us. He is a very special one. He will speak to you about the positive side effects in the use of Froggymouth in eradicating atypical swallowing and oral breathing. But I think that speaking about Dr. Manzini, I have to go way further. Pietro is our biggest user since years now. He was even treating more cases than the inventor of the device, my dad, that was starting the first one. I have to also tell you the wonderful story of how we were meeting at the very beginning. I think that Pietro was hearing about us online, and at this moment we were organizing little lectures, little classes in France of 2-3 hours in Paris. It was the very beginning of Froggymouth, when we were just a young student that I was, and almost retired of my dad. And we were making very small courses like that. And I was seeing on one of those first one guy that was coming from Italy, from Roma, just for our class, for the young product that we were just creating with this little father and son project. It was wonderful. We started to discuss more and more. I started to see that this guy was having a different view. And then he kept working on that. He started to treat cases and cases. They started to develop an actual friendship between my dad, the inventor of the device, and Pietro, the biggest user of this Froggymouth. And now he treated almost 1,500 cases with Froggymouth, and he became our international speaker, showing all the clinical case, bringing all the clinical side on the Froggymouth project. He is a keystone on not only the Italian projects, but also the worldwide project that we are having. He's interested in functions since almost as long as my dad, actually, because he was already in the 80s working with Bergensen, with whom he was co-writing a book. And trust me, in the 80s, there was not a lot of orthodontists that were, first of all, believing in functions, but especially writing about functions and not writing with anyone, because he was back then working and writing with Bergensen. It is such an honor for me to be able to work with Pietro. I was learning so much from him. My dad was also learning so much how we are presenting the clinical cases, how we can treat patients also sometimes in a little bit different way. And I think that it's the most enrichissant, I don't know how to say, but the relationship of my dad that was bringing him the most ideas. So I am so glad to now let the speech to Dr. Manzini, that is about to activate his camera, share his screen, and we may go for the lecture of Pietro. Pietro, I am so glad to let you speak. Pietro, c'est à toi.
Good morning, everyone. Sorry for these technical glitches. Let me introduce myself. My name is Pietro Manzini. I'm an orthodontist and I have worked for about 20 years in a maxillofacial surgery unit in a neuroscience department. And I have also been a tutor at the University of Modena and Reggio Emilia for the final year dental students. This is the city where I'm based. This is my staff. This is my family. And this is my best friend, this big cat. The title of my presentation refers to the fact that I have treated about 1,500 cases with dysfunctional swallowing and breathing disorders using the Froggymouth device. positive side effects. Why? I will show you why. That's because with this device, we can not only solve swallowing and breathing disorders, but also other types of issues. Swallowing. I'll briefly explain what we mean by swallowing, just as if we were in school. Newborns are characterized by the so-called suction swallowing. They do not have teeth, so their physiological pattern is suction swallowing. The tongue is in lateral contact with the cheeks and anterior contact with the lips. The transfer of saliva and food of nourishment is provided by the negative pressure within the buccal cavity, and this mechanism is under the direct control of the facial nerve. By the age of 3, deciduous dentition is completed and the child is chewing. These lead to significant changes in the dental arches. The tongue elevates against the palatine vault due to the involvement of an important muscle called styloglossus. The styloglossus muscle reduces the width of the tongue and facilitates the elevation of its posterior superior part. Then the tongue, with its 17 muscles, acts as a veritable functional matrix and creates appropriate dimensions both on the anteroposterior and on the transversal planes. At that point, the overall dental occlusion, the mandibular occlusion, will adjust to this growth thanks to the work of the trigeminal nerve. This is the styloglossus muscle, and we can say that every day we have about 1,500, 2,000 swallowings per day. And in order for that to happen, there must be mandibular stability. Correct swallowing is when the maximum intercuspation matches with centric occlusion, as in the second case that you can see in the slide. At each swallowing, 68 muscles are involved. That is about 10% of the body muscles. And these are the muscles involved. I go a little bit faster on these things because we will see them in more detail later in my presentation. Atypical swallowing and oral breathing are very much interrelated. In dysfunctional swallowing, the tongue tip may be positioned either on the upper or lower teeth or in the interocclusal space. The middle part of the tongue is lowered or has a unilateral position, while the posterior third rises against the posterior wall of the palate. And of course, we have to keep in mind that the combination of the various dysfunctions can result in different clinical forms. So we can also say that there is not one single type of dysfunctional swallowing, but different types. And from this small diagram, we can see, for example, that a tongue tie can cause a number of more or less severe dysfunctional disorders. An easy way to check the position of the tongue during swallowing, an easy and very much appreciated method, especially by younger patients, is the method that I generally use, which is called a Nutella test. You spread Nutella on the palate, ask the patient to swallow, and see where the tongue positions itself. This can be a substitute for fluorescein. Fluorescein is more accepted, of course, from the scientific point of view, but Nutella, I have to say, is more accepted by patients. And so you can do this examination often and gladly for the patients, even during the treatment, to assess in the various steps where the tongue position is. In this case, for example, we can see that the tongue goes mainly on the right sector of the palate. Of course, we have to keep another thing in mind, that the tongue tip goes in the area of the retroincisive papilla. But it doesn't have to stay in this position. That is just the starting point of swallowing. This is how swallowing works instead. The front part, as we have seen, is on the retroincisive papilla. The middle part goes on the hard palate, and the posterior part, which is inclined by 45 degrees, goes here in the pharyngeal wall area. I hope you can see the video. The video shows how correct swallowing works. Why did I show you this slide? Doctor, look at me. Because with time, I have learned how to evaluate patients by looking at their faces. Patients and even non-patients, actually. I started doing this in airports while waiting for flights. I would look at the faces of the other passengers and tried to understand what kind of occlusion they might have. This is a very good system indeed. And it is also well received by the parents of our little patients. Or if they are already grown up, it is well received by the patients themselves because it is something that no one had told them until then. For example, we can say that this patient is a neural breather. Her lips are incompetent. But if we look closer, we can see that she also has other types of issues. She has a facial asymmetry, orbit asymmetry, labial incompetence, unilateral mastication, and we can also see this from the tilting of the bicommissural plane, the more upwards plane, and she has a preferred or exclusive chewing side. When she smiles, the labial commissure lifts on the working side. And then, of course, she is an oral breather. I don't know if you follow Planus. I personally appreciate him very much. Anyway, at this point, we can already understand what kind of occlusal disorders this patient has with a good accuracy. Of course, there is always a 10% margin for error, but the accuracy is quite good. Certainly, since the patient is a right-side chewer, the occlusal plane on the right side is anterotated, while the other side is posterior-rotated. Oral breathers are unilateral chewers because if they were to chew bilaterally, there would be a problem with food intake, and there would be a possibility that some of the food goes into the windpipe, which would lead to even bigger issues. As you can see, there's a deviation of the mandible towards the right, which is the patient's preferred chewing side, and this confirms what I had previously assumed by simply looking at the patient's face. And not only in oral breathers, the lower lip can be more than twice the size of the upper lip. As for the muscles of the mouth floor, the mylohyoid muscle has an hypertrophic working side and a disused balancing side. This is the patient after 3 months. As you can see, there is already some improvement. If you look closer, we can see all the dysfunctions at the level of craniofacial growth, this orbit, the position of her eyes, and the position of the commissure. And after just 3 months, we can see some improvement. Of course, the patient has started to use Froggymouth, and this is why we have this improvement. Then after the following steps, and especially the follow-up visits after 2.5 years, which doesn't mean that the patient has been using the device for 2.5 years. Usually I have my patients use the device from 6 to 12 months, but there is no fixed rule. Sometimes I have them use it even for longer times. For example, children with finger sucking habits, so these bad habits, or children with some immaturity from the point of view of general development, struggle to absorb, to receive the new input coming from Froggymouth, so they don't develop this automatic behavior during swallowing. Therefore, in these cases, I help them use the device for longer times. Anyway, after 2 years, this patient decided to have recourse to orthodontics rather for aesthetic purposes. And of course, this is quite understandable because at this age, she was a teenager, aesthetics is very important. And then we have to say that aesthetics is always connected to a newly found function. So these are not just orthodontic treatments. I rather call them finishing treatments. So we refine the position of some of the teeth when all the rest has already been corrected. So let's say that correcting the function is the cake, and this is the icing on the cake. As you can see, after 2 years, her face has totally changed. The functional dynamics are much more balanced, while on the mouth floor, before the mylohyoid muscle on the right was more hypertrophic compared to the left sides, and now they have become more balanced. And this is another sign that we are going in the right direction. Why am I always talking about chewing? Because nobody talks about it. If you ask a patient if they have a preferred chewing side, or if they chew alternatively, that is a bit on one side and then a bit on the other side, sometimes they have to think about it because nobody ever asks them. So, but when you enter in a dental office, you have to talk about chewing because chewing is one of the most important things in our psychomotor development in general. And Planas has explained all these things very clearly. So this can be obtained either by taking pictures and then drawing a horizontal line passing through the incisal edge of the upper incisors and a line that passes through the lower incisal edge. So the smaller the angle, the most important is the chewing side. The biggest is the chewing side. While the other side is only a balancing side with a number of dynamics involved from the point of view of the occlusal plane, which are very different. Usually this type of evaluation is criticized because it is not, because this is not, these are not really lateralities, because there is always a protrusion involved. So I'm going to show you another video. I hope you can see it. We can see that there's a right laterality and also a left one. If you ask the patient to chew on one side and you look on the opposite side, you can exclude the teeth based on what we know. I mean, based on the preferred chewing sides. These PFMAs, that is planus functional masticatory angles in very small children with deciduous dentition that have also a certain physiological abrasion, they are horizontal, while during mixed dentition they increase because we have an increased number of teeth, and with the second dentition they have this feature. While we advanced with age. So in the older age, physiologically, the teeth should, of course, naturally, physiologically undergo some abrasions. So we have a greater horizontality, which was typical of smaller patients with baby teeth. There is also another system. This is called G-test. We ask the patients to chew a gum, and we see whether they chew on both sides or they have a preferred chewing side. And this can give us a precise idea whether there are obstacles in some movements of the mouth. And for example, for children who are in the process of losing their baby teeth, sometimes this is a bit difficult because for deciduous teeth, there is never a stable type of occlusion. I work a lot with kids of this age, and also this girl, for example, has asked my help. And we see that her head is tilted towards the right, and the right shoulder is lower. Of course, this girl has a left side chewing preference. She has been treated with aligners plus Froggymouth, and we can see that the occlusal plane is anterotated while the other side is posterior-rotated. So we can make a further assessment that probably most of you do not know about. If we look at the patient's palate, we can find these anomalies. The suture of the median palatine raphe is connected with the spine. So in such cases, we could also assume that there is a scoliotic malposition. The first palatine wrinkles correspond to the shoulders and to the collarbone, while the retroincisive papilla corresponds to the head position. Then let's see what happens while the treatment progresses. Sorry, I have a small technical glitch. I'm trying to solve it. This is the patient at the end of the treatment. So this is the end of the treatment, as I said. And if you look at the occlusal planes, they're just the same on the right and on the left. This is another test, another type of evaluation that I usually do. This was the type of evaluation made by Ricketts on the contralateral canine molar relationship. He said that this has to be done at the end of the treatment. This must be the correct position, while for the lower arch, I usually refer to Planus's ideal arch for a simple reason. Because according to Planus, this is the only way in which incisors during functional lateral movements on the right and on the left can have a head-to-head relationship without losing the contact between premolar and molars. But not strong pre-contacts, just a small, a light contact on those areas, which gives stability to the mandible position. You can see the translation in English on the slide. And now we see the patient at the beginning and at the end of the treatment. We can see that also her scoliosis has been corrected, including the position of the shoulders and of the collarbones, including the positioning of the heads. And this is before and after. Why am I not talking about the chewing muscles, especially the masseter? The masseter usually has two parts, a superficial and a deep one. But at the Bern University in Switzerland, somebody from this university has published this article on annus anatomy in December 2021, and they discovered the presence of another part which was called coronoid muscle, which is anatomically distinct from the masseter muscle and very deep. And they have seen that this part of the masseter is the only one that is capable of moving back the jaw, which is very important to know because sometimes we struggle. And this is the third part. It goes from the zygomatic process up to the coronoid process. And it probably helps to stabilize the mandible, raising and retreating the coronoid process. This part of the masseter is the only one that is capable of moving the mandible back. So let's see another clinical case now. This is also a case in which I used aligners in combination with Froggymouth. I started using Froggymouth a bit before the aligners actually. If you look at the patient's face, you can see that from the craniofacial point of view, and this is a mess. She has really a severe issue, and she is in a developmental phase. She's a teenager. So, in theory, we wouldn't be possible to solve these issues at this time, if not after surgery at the end of the growth. But as you will see, nothing is impossible. This is the patient, her occlusion. She has a class 2 monolateral left mandibular rotation. Then she has left prevalent chewing, atypical swallowing with the tongue going more towards the left, oral breathing. Additionally, she has temporomandibular disorders on the left side, headache in the left temporal side. So I started with Froggy, and after a few months, I also started treatment with aligners. These are scans, and we can see from the scans that the initial scan is confirmed. We see that the curve of P is increased on the left compared to the right. The same is true for the curve of Wilson, which is increased on the right compared to the left. So this confirms the left chewing side preference. So the patient has used the Froggymouth for 3 to 4 months. Then I started using the aligners.
And you can see here in subsequent scans, you can see that there has been an improvement of the SPI curves, especially the left one. That was the more marked one. And then the same for the curve of Wilson, still on the left. So at the beginning, and so you can see the before and after. And so this is treatment in progress, of course, hasn't been completed. But the most important thing is that I did not move the teeth in the lower arch. We just had a rotation of the mandible. And I think that this has been possible because Froggy has unlocked the contraction of this third part of the masseter. And this aspect is very, very important. Well, and with an aligner, even if we put some elastics for the mandible rotation, there is always a tendency to a relapse because the problem is not solved with regard to this deeper part of the masseter. And this shows even more clearly how Froggymouth works. From a morphological point of view, you can see there has been a great improvement, and she will not need adjuvant surgical intervention. I'm now going into biochemistry, neurophysiology, with regard to swallowing reeducation, and in particular with regard to Froggymouth. Dr. Fellows will explain it to you much, much better than myself. And there are several mechanisms that support the change, that is acquiring an automatic behavior, that is long-term memory for this new swallowing program. I always say that a Froggymouth is not a device. It is a device that if you put it between your lips, avoids certain developments and creates a new way to swallow. And there is some clinical evidence, radiological evidence with regard to this, and this functional MRIs. This is a thesis prepared by one of my students. You can see some of the scans, and also there was a radiographic evaluation with regard to the expansion of the palate in a group of children that wore a Froggymouth as a device for atypical swallowing, and the results obtained were rather encouraging. And this is a diagram prepared by one of my colleagues, and you can see a significant improvement with regard to swallowing. Well, this colleague is rather skeptical about Froggymouth. He says, well, sometimes it works and sometimes it doesn't work, but we have the evidence here. There are 3 types of Froggymouth. It depends on the lip shape, and it can be also used with fixed or removable devices. I'm going to show you a few cases. They're quite simple cases. Well, when I say simple up to a certain point with deciduous teeth. And here you can also have a look at the face of the patient, the scabs, and well, this child does not breathe through the nose. There is no nasal breathing. Look at the orbit. The eye is sloping, so there is a problem also with regard to craniomandibular growth. Right, this is after 10 months. So just one thing I would like to highlight. What I have discovered, well, in connection with breathing, perhaps the upper part of Froggymouth stimulates this muscle, which is called multiform. It's a muscle, and when this muscle is relaxed, this muscle helps to put the tip of the nose upwards and opens the nostrils. So it could be of help with regard to breathing, nasal breathing that we would like to achieve. And you can see that with the improvement of nasal breathing, we no longer have some scabs. And from a craniofacial point of view, this was the position of the orbit before, and look at now, and this gives you an idea of what has happened in this patient. This is a 5-year follow-up, 12 months. And 17 months, and you can see something really interesting here. While we were correcting the swallowing problem, there was also a correction of the dental class. So here class 2, and at the end we have class 1. I would say chapeau. And another case, sorry, I'm just going quite quickly through this material. And after 16 months, here we have reached the end of the treatment. And then I visit the patient again. Well, I see him regularly. And this is a follow-up after 4 years and 2 months. And this is the patient occlusion. And then later on, I will come to explain a few more things. Right, this is a very simple case, 6 months, oh, sorry, 4 months. The patient is 6 years old, and this is a relatively complex case after 3 months from class 3. We have a head-to-head. Sorry, I'm going quite quickly here. After 5 months, this is the situation, and after 1 year, we have this head-to-head position. So sometime even after such a long period of time, I asked the patient to wear the Froggymouth again. And this is a checkup after 2 years and 4 months. You could see the class 3 bite problem has been resolved without using any orthodontic device. We just use Froggymouth. This is another case. So this is quite a frequent case. This is the position after 2 years. There has been some transversal expansion, which is always welcome. And there are also cases like these. They're very common. 8 years, tendency to third class or class 3, jaw forward. And in these cases, sometimes people use the rapid palatal expander and then the correction mask for the correction of class 3 bite. And I use Froggymouth, and after 14 months, this is the patient's occlusion. I didn't use any orthodontic device. And in this case, breathing has improved, and from a craniofacial point of view, there have been some changes. This is a case quite similar to the previous one. It looks like a photocopy. Froggy. Another case. Similar. After 2 months, we have a head-to-head. After 7 months. Before and after 7 months. And this is a checkup sometime later. And I haven't used any orthodontic treatment, real orthodontic treatment. I was just waiting for teeth change, and have 2 years have elapsed. The patient did not wear Froggy for 2 years. Well, normally I ask the patient to wear Froggy for at least 1 year. And so if I have to opt for an orthodontic treatment, I would like to start from here and not from here. So these are unexpected side effects, or real side effects. What I've shown you is what happens every day. There is nothing special. And the positive side effects are there. Look at this asymmetry. This is not a soft tissue asymmetry, but this is a skeletal asymmetry. This is within a year. Obviously, using a Froggymouth. Look at those children. They breathe through the mouth, labial competence, and this patient here has mandibular deviation. This asymmetry, you can see that the tongue is on the left-hand side. This is before and after. Same thing. This is a child with backward rotation of the mandible, and here you can see some deviation of the nasal septum, because this is another girl with radial position of the mandible. This is the beginning, and this after 8 months. Well, what about this boy? I started 3.5 years ago. Look at the mess from a craniofacial point of view. This is class 3, terrible class 3, with open bite that we are improving in only 12 months. We have given him the opportunity, well, what shall I say? How can I put it? To recover function. And here is very similar oral breathing before and after. And this boy, class 3, terrible class 3. And after 1 year, well, of course, he will need some orthodontic interventions. But this is the starting point. And this is the situation after 1 year. So, of course, I will start with intervention a year later. There will be less interferences, and in the meantime, I would have corrected a lot of problems. I always tell the parents, first you lay down the foundation of a house, and then you build the house. And we have to think in these terms. Well, I'm showing all of this. I take a lot of pictures. I put it in the clinical records of my patient. And sometimes I show the parents what has happened. And because we're a dental practice, of course, the patients, but also the parents are flabbergasted because they don't realize day after day of what's happening. And this also reinforces motivation. And also will help them in following the journey ahead. Of course, there might be some orthodontic interventions, but we're trying to show them we're not just dentists who are moving teeth, but we're doing more important things, because with crooked teeth, you can also live 100 years, perhaps not 101 years. But with these problems, it's a bit more difficult because patients encounter more problems as they age. Now, very, very quickly, there are two classification types, Malapati school with a protruding tongue, and Friedman. And the best is the first. And I always put this together with the patient record. We show the patient the relationship between the classification and the problem by using this grid. So just to give you an idea, this is one of my patients, and is a 0.4. And this is the most serious one. This is a younger girl. You can see a reddening inside the mouth, and a reddening is often the precursor of obstructive sleep apnea. I don't know whether you can see in the film. This is the classic atypical swallowing. And this is the patient at the beginning, and this is the patient after 6 months of wearing Froggymouth. So we started in the most critical condition, and now let's say the situation is almost normal, and this just in 6 months. And of course, the child's swallowing function has improved. You can see there's no tension here and in this position. So before and after, I'm just, sorry, I don't want to bore you. I'm just going forward. I just put here, Froggy. It looks as if this patient wouldn't need any tongue re-education, but in reality, he does need it, because after 2 months, we have a right prevalent chewing, and here interposition on the left side. So there's a very precarious occlusal plane that will stay like this. There will be a change of structure during the program, and then there'll be a change once he loses his milk teeth. But after a few months, he is started chewing on the other side. There is no tongue interposition, and this is thanks to Froggy. So, and you can see this is overbite, and you could see the difference in just 8 months, and this is, well, let's say almost a normal bite. What is important is that the occlusal plane has improved, but the things that really impressed me is that this boy had this nasal septum deviation, but this was resolved. There is a reason. Because when you're having correct breathing from a nasal point of view, then we have turbinate hypertrophy, in this case on the left hand side, that moves the cartilaginous side towards the right. So we restore breathing, and so it is possible to correct these problems. This is another assessment that can be made. You can overlap here, and you can see the improvements over time. This is another patient, and from a morphological point of view, this is at the beginning, and this is now before and after there was a 3-year follow-up. Well, and I always say it's not an orthodontic device. Another case, and so you can see here another case of nasal deviation, but for the whole mandible. So we have to adjust the masseter, which is much more hypertrophic compared to the other side. And slowly but surely you can reach this situation. And then, if necessary, we can opt for an orthodontic intervention, a more targeted intervention without any interferences in terms of swallowing and breathing. And then cross-bite, lateral and anterior cross-bites. Of course, we need more time to correct them, but it is possible to correct them. And this is the movement for correction. And, well, the cross-bite, of course, could be more or less serious. Of course, more serious cases are more difficult to correct. But in this case, in the specific case, after 15 months, if you have a look at the occlusion here, now it was off-centered, and now we resolved the lateral cross-bite problem. And we have to bear in mind all the implication, because with cross-bite, the tongue positions itself here. It seems a contradiction, but it is like that. Another cross-bite case and another solution. And here we have this boy. It's got some problems with regard to orbit, and so the orbit, why orbit? The maxillary bone is in connection with the sphenoid, and the sphenoid contributes to the construction of the internal part of the orbit. So if the maxillary bone is dislocated or has some positioning problems, this has an impact on the sphenoid position, but also on other aspects which are quite important, because the sphenoid, also abiotics, and so there are other problems with regard to the sight. And some children have problem because of this. So we know that astigmatism is very frequent in these children, and we know that when we correct these problems, the children stop wearing glasses. Just to give you an example. This is before and after 2022. You can see that from a morphology point of view, things have changed. But also the ears, the outer ears are connected with the temporal bone, and there are some asymmetries here, quite important asymmetries, and they give us an idea of what the problem may be, even a occlusal problem. And this is the assessment system for the ear axis, and they show us where the patient can chew. Sorry, this would require longer explanation, sorry, and we should have more time available in order to go into details. But anyway, you can see during the treatment, during the re-educational treatment with Froggymouth, you can see an improvement. They are now in the right position. And now let's have a look here. This was the occlusal plane at the beginning, and this is how it looks now. And how the orbits were and how they're now, and the ear's position. And this is a very important case. This girl forward tongue posture. You can see that there is no teeth contact except for the teeth at the back. And there is always this tendency, dental class 3 and then skeletal class 3 as well. But this is something else. So this girl started using Froggy, and many things improved during time, and this is a follow-up at 2 years, 3 years from beginning of treatment. And here you can see some nasal deviation. But the important aspect is the following. Here, we start with orthodontic treatment. Here or here? Here we have class 3. And here we have class 2, deep. So you can understand that if I start with a treatment here for class 3, so I will highlight its natural conclusion, which is a close by the class 2. So we have to ponder on this to re-educate the tongue, removing these interference. So all this will allow us to start with a treatment plan that is more accurate and that is connected with less relapses cases at the end of the treatment. But we have to bear this concept in mind. Another case, I'm moving a bit quicker here. Pietro, ancora qualche minuto a disposizione? Bene, d'accordo. Allora, so I would say you can see that from a morphological point of view, the mouth has changed completely. It's a different face. Here we had hypertrophic masseters, the orbit. So we now reached a balance. in 1 year and 3 months. Well, these are small miracles. Well, they are small miracles. And you can see from the morphological point of view, well, you can also show the parents. And if you show this to parents, the parents will love you for your entire life. There are so many interesting cases. I also had some cases with adults, but this is a boy with this kind of breathing, and with a froggy, you can see that now the nose is free. He can now breathe through the nose, which is very important. And during the pandemics, well, we have all forgotten one very important thing. That is that we should breathe through the nose, because in the paranasal sinuses, a natural gas is produced. It's called nitric oxide. And there has it's been studied in the first SARS epidemics, and they found out that apart from being a vasodilator and helps to avoid clots in the blood, well, in the first SARS epidemics, they found out that it was interfering with the replication of the virus. And this point has been researched. Its functionality has been researched. But Iñarro, this an American pharmacologist, I think he won the Nobel Prize in 1998. And no virologist, well, at least here in Italy, ever talked about this. I carried out an epidemiological study with GPs and friends, and with a questionnaire, with some question, of course, they had to reply to some questions. I wanted to find out how many people who had COVID with symptoms or even ending up in the intensive care unit rather than the resuscitation unit. I wanted to know how many of those people were breathing through the mouth. Well, 87.5%, that is the percentage. So I would say that nasal breathing is even more important than swallowing. Although, of course, the two aspects go hand in hand, because when we swallow, we don't breathe, and vice versa. So there is a correlation between these two functions, a very important correlation. I'm sorry, I wanted to show you so many other cases. Well, I know that you allowed my friend Pavone to talk a bit longer because we started 10 minutes later. Well, anyway, I don't want to bore you. And but have a look at this. Some other cases, nasal septum deviation. So I would like to thank you for your attention, and if I have the opportunity, of course, I will show you many more other interesting cases, even adult cases with other problems, not only occlusional problems, general problems connected with other organs caused by incorrect buccal function. And if I have the opportunity, I will show you. I will show them to you. And thank you very much for your attention.
Worked this summer. You, me, and my father, we've talked about this project. So, well, there's been a lot of questions during your presentation. I think too many, actually. So we'll actually switch to the other platform and then to Facebook with the help of Matteo Ricottini, the Italian distributor.
The Italian distributor, to answer all your questions that you have about the lecture of Pietro, because it is impossible to make a choice. Pietro, we are so glad to have you there. I am sorry we had to go further because we are already very late now, but it was such a pleasure.
A great honor to have you as a participant. We'll continue our good work with our future project with more details later on. Thank you very much, Pietro, and hi to Goricottini.